Sorry about that. So nursing interventions to promote, maintain, improve oxygenation. When we want to promote lung expansion, um, one of the first things that we can do is uh, change position. Uh, Typically, patients will breathe better in an upright position, so just raising the head of the bed to 30 degrees or more may help alleviate some distress. Positioning for lung expansion also means repositioning, so turning them from side to side. This helps prevent stagnation of fluid and the potential for the alveoli to uh, stick together so that they resemble a deflated balloon, because then that makes it airless and the patient has to work harder in order to breathe, to take a deep breath and open that alveoli back up. Um, if we have a problem, say, with a pneumothorax, which is um, uh, deflation of an entire lung, we want to position the patient with the good lung down in order to promote perfusion. Um, if they have an abscess or bleeding within the thoracic cavity, then position with the bad lung down to prevent drainage into the good lung. Incentive spirometry is a method of encouraging the patient to take a deep breath by using the tool that helps them to visualize how well they're doing. Breathing exercises can include uh, focusing on abdominal breathing by having them place their hand on their stomach, and when they take a deep breath in, they should feel their stomach rise. Also, having patients take a deep breath and cough will help to clear the airways so that they can breathe more deeply. Pursed lip breathing is especially useful for patients with COPD because by breathing or exhaling against pursed lips, so like they're blowing out a candle, um, helps to keep the smaller airways open and allows for more air to be removed from or out of the alveoli so that greater volumes of fresh air can be brought in when they inhale. So hopefully that makes sense. Because in COPD, air tends to trap within the alveoli, and then there's no ventilation. There's no air moving in and out. It just becomes stagnant there. And so we want to be able to get rid of the stale air and bring in fresh air. Diaphragmatic breathing is focusing on movement of the diaphragm. Oh, pardon me, in order to take a deeper breath. Intermittent positive pressure breathing is similar to CPAP, but when the patient takes a breath in, additional pressure forces more air than they would normally take in, so that again, air gets deep into the alveoli. And chest tubes are used in the case of a pneumothorax or hemothorax, where fluid or air is building up within the chest wall cavity and actually putting pressure on the lungs and causing one or both lungs to collapse, which would significantly decrease the volume of air that could be taken in. Coughing is an effective technique for promotion of patent airway. Having the patient take a deep breath and cough every 1 to 2 hours mobilizes secretions and removes them from the airways, allowing for the free flow of air. Sometimes patients have an ineffective cough for whatever reason, whether it's because of medication, pain, um, weakness, then we have to employ suctioning techniques. And there are many types of suctioning, whether we're just suctioning the mouth and the back of the throat, the nose and the back of the throat, or we can go through the mouth into the trachea, nose into the trachea, or we can suction the trachea if the patient has an artificial airway. And those are skills that you will learn in lab. Remember, anything that goes below the larynx has to be sterile technique, so as not to introduce any pathogens that are not already in the patient's body. With suctioning, we have to remember that the goal is to remove secretions. However, it cannot be underemphasized that while we are removing secretions, we're also removing air. And so we're removing oxygen from the patient. So it's a safety measure is to limit suctioning to 10 to 15 seconds per pass and limiting it to 2 passes per suction. We want to make sure that the patient is well oxygenated by checking the oxygen saturations, and if they have oxygen on, by even increasing the oxygen for flow for a few minutes prior to suctioning. Suctioning too frequently or for too long a period of time not only removes air and oxygen, but it can also damage the tissue in the nose, the pharynx, or even the trachea. Now, artificial airways are typically utilized when mobilizing pulmonary secretions. It's important that we move the secretions up and out in order to prevent blocking of airflow, and because those secretions are going to be a nice little environment for pathogen growth, and so sets the patient up for infection. Coughing, we've talked about, is one of the most effective means of mobilizing secretions. However, the patient needs to be adequately hydrated so that the sputum is thin enough to be expectorated. And this might be complicated by patients who are on fluid restriction or are taking diuretics, or for some reason are unable to take in adequate volumes of fluid. Humidification refers to the environmental air, and especially if a patient is on oxygen. Anytime oxygen is used for greater than 24 hours, it needs to be humidified, and when the flow rate exceeds 2 liters per minute for any length of time, it should be humidified. Oxygen is very drying to the mucosa, and it will cause consolidation or thickening of the sputum or pulmonary secretions as it draws fluid out, and makes it that much more difficult for the patient to get rid of those pulmonary secretions. Nebulization usually involves medication through a nebulizer, or which just breaks the medication and the fluid up into small enough particles to be inhaled, which then loosens the secretions. And chest physiotherapy is a combination of vibration and techniques that help to mobilize secretions. Chest physiotherapy typically involves postural drainage, meaning we actually will turn the patient head down so that we can drain using gravity the lower lobes of the lungs. We typically accompany this with percussion and vibration. Now, percussion is different than what we do during assessment. With percussion for chest physiotherapy, we're using our cupped hands and beating, essentially, on the patient so that it traps air in the cupped hand, and when we slap it down on the patient, it causes vibration and will break up the mucus so that it can mobilize or move. We can also just do vibration. Percussion is bigger hand movements, and vibration is smaller hand movements. With percussion, we take our hands off and slap it down. With vibration, our hands remain on the patient, and we're just jiggling, I guess, but creating that movement that will, again, tissue perfusion typically will have something to do with promoting adequate circulation. When using oxygen, we have to remember that oxygen is a medication, and therefore we must follow the 6 rights of medication. So it requires an order. We we have the right patient, the right route. And for oxygen, it means, is it by mask? Is it by nasal cannula? Is it through the trach? What route is it supposed to be given? So sometimes patients require oxygen in order to maintain healthy levels of oxygenation to promote tissue perfusion. If the patient is experiencing hypoxemia or low levels of oxygen in the blood, then they're going to require external sources of oxygen. Oxygen is a highly combustible gas, and so that means we need to limit sparks and flames and smoking in the presence of oxygen. One of the most common methods of delivering oxygen is the nasal cannula, and it's typically just 2 prongs on a tube that connects to the flow meter that goes into the wall. The prongs are curved and should be placed in the nares with the curve towards the back of the throat. Nasal cannulas can safely deliver flow rates up to 6 liters per minute, and again is the most common method of delivery. Remind the patient that it doesn't do any good if the nasal cannula is on the forehead or under the chin. They're not getting any extra oxygen. Now, sometimes you will see a patient put the nasal cannula in their mouth, and if they're breathing through their mouth as opposed to their nose, then we might be okay with that for a short period of time. You see patients will do that. They've been up to the bathroom and they come back from the bathroom and they're breathing through their mouth, taking large volumes of air through their mouth, and it doesn't do any good if the cannula is in their nose. They're not breathing through their nose, so they're going to get more oxygen that way, and that's okay for a limited amount of time. But if they do that all the time, it may be preferable to get an oxygen mask. And an oxygen mask typically fits over the mouth and nose. It can deliver, a simple mask can deliver slightly higher rates of oxygen or concentrations of oxygen than a nasal cannula, and can be used with flow rates up to 10 liters per minute. It can be used with or without humidity, as can a cannula, but for both, we want to make sure that humidity is used when appropriate. There are other types of masks. We can use what's called a Venturi mask, which allows us to choose the actual concentration. With a nasal cannula and a simple mask, we just go by flow rates, and it gives us a range of oxygen percentage, such as you probably know that room air, what we normally breathe, is 21% oxygen. So every time we add oxygen, we're going above that 21%. If we have a Venturi mask, it allows us to deliver higher concentrations of oxygen, and it allows us to be more specific in the percentage of oxygen that's being delivered, as opposed to just liters per minute. Some oxygen masks have a reservoir bag, and so this is considered typically a non-rebreather mask, and the bag allows for higher concentrations of oxygen. So the bag fills up with the pure oxygen, and the additional pressure between the bag and the flow from the wall increases the concentration. If the patients mask has a bag and the bag is not inflated, the patient is breathing in carbon dioxide, which is not the goal. So if they have a bag on it, it needs to be inflated or it isn't functioning properly. And anytime that you are using oxygen, one of the things that you need to be aware of is what is the patient's history. A patient with a history of COPD, chronic bronchitis, or emphysema, which are the two components of COPD typically, actually have a different drive to breathe. We breathe when the chemoreceptors in our brain are signaled by too much carbon dioxide, and it says, hey, you need to breathe out because we need to get rid of this carbon dioxide. Patients with COPD actually breathe because of low levels of oxygen in the blood. So when we give them excess oxygen by an external source such as a nasal cannula or mask, and we raise the level of oxygen in their blood, then their body says, hey, we have enough oxygen. We don't need to breathe anymore. We'll just take a little break, which can be detrimental to the health of the patient with COPD. So, as a general rule, if a patient's history is unknown, then we rarely will give them more than 2 liters per minute of oxygen until we can establish what exactly is the patient's problem. Now, some of the things about nutritional therapy that can aid oxygenation or promote tissue perfusion is maintaining an ideal weight. Isn't that true about anything and everything? The more our weight is maintained, the better off we are. We also have to make sure that what the patient does eat is quality. We want to maintain muscle strength, which is so important to the expansion of the lungs, which, by expanding the lungs appropriately, more oxygen comes in. The more oxygen that we have, if the circulatory system is adequate, the better tissue perfusion that we're going to have. Also, the frequency and volume of meals can promote or hinder tissue perfusion. Patients typically, and especially like COPD patients or patients experiencing prolonged respiratory distress, will do better with 6 to 8 small meals rather than 3 large meals. Because the large... Yes? Look on my head.
I would like that background.
I really wouldn't care. They would just laugh. I'd just be like, that's my husband. Promotion of activity tolerance. One of the problems that patients with, especially chronic oxygenation issues, will experience is activity intolerance. And one of the things that can help is progressive activity program. And that simply means that we're going to start where they are and gradually add things to their ability. So today they can walk 10 feet twice a day, tomorrow 12 feet twice a day, 2 days later 14 feet, whatever it is we need to do to get their activity tolerance. And of course, it's not just about walking. It's activities of daily living, um, just being able to do normal everyday things that they need to be able to do to take care of themselves, and helping them take those baby steps is what promoting activity tolerance is all about. They also have to be taught about energy conservation. So it's important that they take rest periods so that they're not overexerting themselves. So doing a few small things and then taking a break, and then doing a few small things and then taking a break, as opposed to trying to do their whole list of everything that they have to do at once and then taking a longer break. They're really better with short bursts of activity and short rest periods, and then repeating that cycle. Teaching them about stress management will help with their activity tolerance, and then of course promoting good nutrition is